So, welcome to the final session. I'm sorry I couldn't be with you this morning. My name's Julian. What? Oh, switch on. Yes, okay. He's given me the sign. Switch on. There you are. Can you hear me all right? Yes, okay. So I'm a cardiologist. I may not have a catastrophe that affects thousands of people, and I may not have stocks and shares, but like you, I have a heart. So I think what I'm going to say this afternoon will interest all of you one way or the other. The other thing to say is the second speaker in this session can't be with us because he's unwell. So I'm going to keep roughly to time, so we can either finish early and go to the pub, or you can bombard me with questions about your brother, your mother, your father. So in my day job, I'm a plumber, okay? I plumb things like that. Those are coronary arteries. You have them, okay? They're about 3 millimeters across, and yes, they get clogged up as you get older. So that's my day job. If people ask me what I do, I say I'm like Dino Rod. I think we all know what Dino Rod do. And people go, oh yeah, you unblock the drains. I said, yes, I unblock the drains, but unlike Dino Rod, I don't charge a call-out fee, sadly. But in the last 15 years of my existence in Sheffield, I've come to work at the university with some very clever people like you, okay? I'm not a modeller. I'm not a mathematician. I don't sit down and think, blimey, that was a really beautiful equation, you know, though I do realise such things exist. But what I do is I have dreams about arteries, which is kind of a bit sad, really, but this slide summarises it, really. I've got into the field of modelling coronary artery disease because, as you will see, we're at the very beginning of it. I listened with awe to the last two talks because clearly in the world of finance and in the world of catastrophes, it is essential to have decent models. That penny has not yet dropped in the health community, okay? It's only just starting. So if you want a job, okay, get into health. So, modelling in the coronary disease in current clinical care. Yep, that's it. That's what's going on at the moment, okay? And we're trying now, there are papers being written on it, not just by me, but by others, to try and get it going, all right? So at the moment, it's very much an empty room, but we hope that room will get filled up soon. This is what we're talking about, okay? Coronary arteries, like a crown, shaped like a crown, hence coronary. When the good Lord designed it, he clearly wasn't a fluids engineer, because it would have been better to design it as a ring main, so that if one blocked, then the blood would go around the other way. Unfortunately not. They're like branches of a tree, so that if one major branch blocks, that bit of the... I've really got your attention here, haven't I? Everyone's going, oh, should I have had that second donut? And of course, this is what you don't want to happen. This is a diseased artery. So when they get diseased, the disease goes inwards. This is atherosclerosis. Okay, Nobel Prizes have been won trying to work out how it happens. We know that smoking, you know, diabetes, high blood pressure, all the things we know about, predisposed to it, but genetics are the big thing. And we don't understand them completely, despite knowing about the genome, and we're of course here in Cambridge, where a lot of that work was done, we do not know yet what all the interplay of the genes are that cause that. Anyway, the result of that narrowing is that the supply of blood flow down here causes our patient to do that. So he goes to the doctor. What happens? He has a wee chat with his friendly local GP. This is my rather splendid 1959 surgery in South Yorkshire. And he probably follows the nice guidelines, puts you on some tablets, advises you to stop smoking, which everyone does in my part of the world, and refers you up to the hospital. That's my hospital. Whereupon you see someone like me, who takes the history again to extract, after years of training, what sounds like a history of angina, chest pain. To confirm the diagnosis and to see how bad it is, we do a number of things. Here's our old friend, the treadmill test. That's a good one. But nowadays, NICE tell us to do these things, which are CT scans of the coronaries. And there are some fancy other imaging tests we can do. And if it all looks very likely that that's what you've got, and it's not being controlled with the tablets, meaning that the blood flow down that diseased artery is really not responding very well to the medication, then you come and see me in one of these rather fearsome looking places, which is called a cardiac cath lab, catheter laboratory. And you lie the patient down there and you shine x-rays through them and you pick that image up and you inject contrast down the coronary arteries so you can see them. And so you see where the blood should flow and you can see a narrowing. And would that all my patients had a simple one like that. They don't. It used to be like that, but it isn't now. The population's getting older. Disease is getting more complex. There's more obesity, there's more diabetes, and arteries are getting worse. But people are living longer. So you're getting this curious combination of longevity with bad disease. On the basis of looking at that, and this is the key point of my talk, actually, we have to decide, do we stick them on pills, keep them on pills, pat them on the head and send them away? Do we put a stent in? Or do we send them to the barbaric surgeons that work on the next floor for them to split their chest open and put some grafts on? What a terrible business. What an awful choice to make. And life-changing. So here's our patient with a single narrowing, and my job as the dino rod man is to inflate a balloon, put a stent in, which looks like a metal sort of mesh. Lots of, incidentally, these are made by companies like Medtronic, Boston Scientific, and Abbott. And you can put a 1 with 10 zeros beside what those companies, no, probably 5 followed by 10 zeros beside what those companies are worth. That'll be just one small part of their business. Give you some idea, we reckon about probably 3 to 5 million of these procedures are done worldwide and going up fast, particularly in the Far East. So, decision making then. What's all this got to do? My life is a succession of decisions, and I'm really not making this up. And the more I think about it, and the more I meet people like you, the more I realize how scabby those decisions are, and how precarious the evidence is that we base the decisions on. Typically what we do is we read a paper in the New England Journal of Medicine, which is kind of our top one, or Lancet or something, and it says on average, if you give say 5,000 patients this drug as opposed to placebo, they do this much better. Great. So everyone goes and prescribes that drug, you see. No modelling, no individualisation, no personalisation. And it's that aspect that we have to put right. Anyway, to come back to this, so we're left just looking at this angiogram saying, well, it looks a bit narrow, I'd better put a stent in it. How long is the stent? Where am I going to put it? And there's an old joke. If you put 4 cardiologists in a room with an angiogram, how many opinions will you get? Yeah, 5. Well done. Very good. Yeah. Usually it's... Kenny, my colleague in Sheffield, he plays a joke on me. He'll show me an angiogram one week and he'll get an opinion off me. And then you've got it. Yeah. Anyway, so what science can we do? The science is passing this thing called a pressure wire down the artery and measuring the pressure gradient. Hooray! We're into the 18th century. Great! We can measure pressure. Fabulous. And then we give a drug that maximizes blood flow, so it sort of mimics exercise. And you can see the pressure gradient widening. And if it gets wider than a certain gradient, then we know the lesion is probably, again, on average, taking a population in a study, worth treating. And on average, those patients will get better. But of course, there's a grey area. And some you'll treat inappropriately and some won't. Anywho, that's called a pressure wire. And it's called an FFR, fractional flow reserve, that measurement. I won't bore you with the details, but it's what we should do, and we're not even doing that. We're doing that in about, I don't know, 10% of cases. So, modelling then, where does that come in? Well, my whole idea was, let's take the angiogram and let's get my modelling friends to do something useful for a change, you know. And I'll give them some images. They can build a mesh around the segmented artery, and they can calculate for me, using some CFD, computational fluid dynamics, what the pressure gradients are, so that every patient who has an angiogram can have at least a surrogate modelled pressure gradient. You wouldn't believe how difficult this is. This simple little thing. So, you know, when I showed this to Rod Hose, who's a mathematical modeller, he spent his, just to orientate you, he spent most of his life working for Fokker in the aeronautical industry. And then in, I think it was, oh yes, he worked for Cadillac, but he did all that, you know, did the aerodynamics, and he got bored. So he thought, I want to do something useful for patients. So he went into health. And he took a pay cut of 90% to come and work for the University of Sheffield. But thank goodness he did, because, you know, he says to me, well, I can model that. Just give me the data. Of course, the difficulty is the data is flawed. We've just heard beautiful talk about, you know, parameters. Well, the parameters here are ropey, to say the least. This is a two-dimensional image of a three-dimensional object that has flow, and it's moving around. It's terribly difficult. Anyway, we did it. We built the model, and from the pictures, we segmented it. We put a virtual 3D mesh inside it. We gave it its boundary conditions, and we told it exactly what we wanted, and we calculated the flow, and we calculated the pressure. And the best thing is, for doctors like me, you get a nice pretty picture, you see. And doctors love pretty pictures, okay? And if it means red, then you treat it, you see? Okay, and if it's green or blue, you don't. We're at that level, okay? All right? So, how far have we got with this? Well, it's in the academic literature. We are able to do it in patients. Is it in the widespread use? No. We're at the point of commercialization. So if anybody wants to come up to me afterwards with a wad of cash, very pleased to talk to you. The advantages would be huge. We can apply it to, you know, in the UK, there's about 250,000 angiograms, pictures, and only about 100,000 angioplasties, of which only 10,000 are getting the pressure wire. So potentially 250,000 of these could be done, and everyone could have their pressure gradient measured with no wire, no drugs, be cheap because it's a bit of software, isn't it? And it could be done anywhere. It'd be rather super. But even that simple bit of fluid mechanics is tricky because it's biology. You know, we've all done enough biology to know biology is a soft science, it's a bit tricky. And when you get to patients, it gets even fuzzier. So imagine, if you will, Ohm's law. It's a bit like Ohm's law. So if you apply a pressure across a resistor, okay, then you get a certain amount of flow. Well, we understand that. The problem is the resistance in the circuit isn't just the narrowing. It's also these microscopic downstream vessels. So if you've got someone, for instance, who's had a heart attack before, or they've got high blood pressure, or they've got diabetes, or something, or something, or something, then that resistor is the big unknown. And that can screw up your model. Because we can't get right down into there to find out what's going on unless we pass wires and things right. And I don't want to pass wires right down. So our current piece of work is to try and take parameters to feed into the model that are a bit easier, that might give us a good idea of what's going on down there. So we did that, and mercifully, luckily, I think, probably, if I'm honest, the measured resistor and the modelled resistor downstream seemed to be pretty good. And to do that, we had to invoke someone that many of you will know, Steve Billings, who is based in Sheffield. He's now just retired, actually, as an engineer, but used his NARMAX technique to look at all the different parameters, a very elegant system to feed into the model. So we're doing all right. So then we took it forward, having put the resistor in, to the actual FFR. This is the clinical measure of the pressure gradient. And here's your measured, the MFFR, and here's your virtual or computed FFR. And plot the two. So we actually took these patients and we measured it, and we looked to see how good the model was. Okay, and it might horrify you to look at that. Say, right, that's rubbish. You know, so the lines, by the way, these are the decision points. So what you want is everyone in that square or that square. That one you leave alone, and this one you treat. Actually, when you drill down, we didn't do too badly, because there's only two really red spots there where we got it a bit wrong, and they weren't horrendously wrong, you know, considering what doctors do to patients. Okay, so, and of course we've got to do quality assurance. So, you know, this is all new to us. You know, in industry, in finance, you'll be, this is, this must be old hat. But for us, it's new stuff. Oh gosh, we'd better check this, you know. So we take the images, we model it, we remodel it, we recheck it. And I have to tell you, there's quite a few inaccuracies. It's been a struggle getting funding. We've still only got research funding from a couple of bodies, one of which is the National Institute of Health Research. And we're in the business of setting up the model. We've had to have a software developer. Me, you know, a plumber with a software developer. This is new stuff. Wow. We've got to revalidate it, and then, of course, you can't just go out and flog it, because it's patients. So what we have to do is to go and get it kind of CE marked, if you're talking about Europe. You remember Europe? Or, you know, the Medical Health Regulation Agency, MHRA. We have to get that approved in the UK. That's a big deal, because this is a decision-making tool that means this patient's going to get a stent and this one's not. This one's going to get bypass surgery, this one's not. Big stuff. And it meant that I had to learn a whole new language. I mean, you know. So we've got someone sitting there in front of a big screen doing this. And apparently the segmentation is the really tricky part. And Vignesh tells me he's abandoned the linear least squares fit. Don't ask me. Don't ask me. But he's now using a Fourier representation and optimization technique. I said, well done, Vignesh. Terrific, I said. But there are lots I'm learning about this that we're able, I think, to make the model more sort of usable. So what we have to do in the patients is give a drug, and I'm finding that we can model what happens when you give the drug. So we can add that to the model too, and we've got one of our PhD students on that. She's done a great job. I've learned something else. It's taken me, I must say, 2 decades to get modelling, right? Incidentally, most of my consultant colleagues still don't know what it is. I think it's something with plasticine, you know. But anyway, the thing about the modelling is it can predict things that we can never actually test in reality. That's the first thing. The second thing is you can go back and test hypotheses that come up. So when Martina did this work on the effect of the drug adenosine, so you've got a graph here of time, and you've got a graph up here, the y-axis of the pressure gradient. It wasn't suddenly from one level to another. It fitted a beautiful curve, which is quite consistent. And it turns out that people like me in the real world were measuring it completely wrong. Okay, and she says, from the model, you should be measuring it there, but you're not. And we looked at what we were doing, and she was right. We were all over the place. Some people were measuring it at the minimum, some people were measuring it there, some people were measuring it with the wire down, I mean. And with the model, we can do it precisely at what we predict to be an exact time. And that's fed back to the clinic. So we're now writing a paper to the cardiologist saying, you're doing it wrong. Do it like this. I love it. And does that affect treatment? You bet it does. So you're familiar with the boxes by now. So Martina's work showed that actually, in doing it wrong, we're treating quite a lot of people wrong. Okay? A lot of them are actually getting a stent when they shouldn't. And that's dangerous, because if you put a stent in someone, the blood flows over it and you can get a blood clot if you don't take drugs. And it's about a 1% risk of a blood clot, so it's not trivial. So this is really important work, and I'm very excited by it. So it's modelling, feeding back immediately to the clinic, which I think is just great. And then Marco's working on a reduced order model, which he's explained to me about 12 times. I still don't quite get it, but basically said, Jules, don't worry, it's a black box, okay, you know, and what you do is you feed in all your cases, it learns from them, so you come with another case and it takes a shortcut. I said, thank you, Marco, now you can go for coffee. So that was terrific. Here's another example of things we didn't know that the modelling's taught us, okay? So if you take an artery with 2 narrowings, please forgive me if we've got any fluid engineers in this room, because this has been known for about 150 years, okay? But we didn't know. Cardiologists didn't know, and we're the ones that treat you. Okay, there is a certain number, this is the velocity, this is the pressure drop over those 2. Fine, we understand that. 2 in a row, you get 2 pressure drops. Great, no problem. If you space them out a bit, that's what happens. Very understandable. Okay, but if you take one at 70% narrowing and one at 50% narrowing, then something very peculiar happens. So what happens is the pressure drops over the first one, and it goes up over the second one. Oh good, I'm not the only one. Right, that's lovely. So I didn't know that, and Rod said, yeah, we did know that, and he sort of dusted off a paper from goodness knows when. But I can assure you, in medicine, that's not known. And we would never know it, because we'd never have looked in the patients with the wire. The modelling has told us this. It's great, isn't it? Modelling feeding back straight away. So another of my students is now working on modelling stents. Okay, now you can model, as you know, at various scale levels. I'm sure you've had numerous talks about that. Multi-scale modelling. So we're at the millimetre level, aren't we, for stents? But there are people interested, and I'm sort of one of them, interested at the very, very low level as well, down at the 100 micron level, 10 microns maybe, as the blood flows over each bit of the stent. That's very interesting. And then you get into how stents affect atherosclerosis. But that's another talk. Let's leave that. Anyway, Becky's doing her PhD on modelling the stent as a whole, so its effect on blood flow. Okay, so here we've got a real Sheffield patient. You've seen the angiogram before. There's the narrowed artery there and there, two different views. And then I've actually put a stent in, and that's what it looks like afterwards. Thank you, yes, good. Whew, a tough audience, huh? And she's modelled exactly what I've done, and she's predicted what the pressure gradient would be, and actually it was right, thank goodness. So what she's going on to do is to develop a treatment planning module so that cardiologists can say, yes, have a cup of coffee, look at the angiogram, I'm going to put in a 3.5 by 20 stent there and a 3 by 8 there. Let's see what the effect is. Not good enough, that one needs to be a bit longer, that one needs to be a bit wider. I think it's very nice. This is, it's what will happen in the next 10 years, 5 years hopefully. There's the virtual stenting, and we've validated it, and we're just sending that out for publication now. This is all very nuts and bolts, isn't it? I'm thinking, you've had these talks about maps of the world, and are we going to get a stock market crash? And all I can do is one little artery, So the impact is this: you get of Becky's work, that you get your angiogram and you get a nice pretty picture, and then another nice pretty picture showing the red disappearing as you put your stents in. Is it important, all this? Yes, it is actually. We know that if you pass a pressure wire and do this properly, using the 18th century technology, here he is, Isaac's beside us here, looking a bit rough, I have to say. I'm not sure I'd buy a second-hand car from him. And I don't know, those of you near the front will have noticed this clock, which I'm finding really distressing. Those of you at the back can't see, but there's this clock here, and the hands are going round at a huge rate. And I'm told that Stephen Hawking sometimes comes along. Well, I'm sure he'd have a few things to say about that. I don't know what it says about our velocity vis-a-vis the centre of the galaxy, but I'm very worried about it. Anyway, yeah, well, yes, yeah, quite, yeah. Yeah, perhaps I ought to speak in a very high pitch. No, it's the other way round, isn't it? Right, so FFR does change management in a surprising number of cases, okay, which is work we've been doing with other groups, not just me. So this means something, and the model is going to mean something, and we're going to have to validate it. Now, models in medicine, very, very serious business. Early stages, validation is the key. All my colleagues will turn to me and say, how do you know? Prove to me that it works. Tell me that it's accurate, okay? And it's a challenge. So we're going to take real-world data and compare against our model from not just from Sheffield, but from Cambridge, from Oxford, from Southampton, from Leeds. We have to do it. But even I've started to think a bit bigger. You've inspired me. So this business of the pressure gradient, it's only a number. And I actually trained at Cambridge. How about that? You didn't know that? You didn't know that, Peter? You did know that, okay. I told you. Oh yes, my memory's going. So, FFR is just a number, but we treat people, okay? So these are people of the same age, but different activity levels, different expectations, different lifestyles, different frailty levels. And these are patients, the sort of patients I treat. I treated a man only yesterday who was more like that than like that, and expectations differ. So his expectations were, can I live another year? Can I get out of hospital? Am I going to be a burden to my family? Whereas this lady's expectation was, can I go on holiday 3 times a year? Quite different. And then there's the social context. So we really have to think a bit bigger than just a number, and I'm only starting to get into that at the moment. The other thing I found fascinating is... Okay, who is he? Yeah, so people in the audience of a certain age will remember James Robertson Justice, the character of Sir Lancelot Spratt. And I'm a consultant in the NHS, but I jolly well don't go around like that. Though I am secretly a bit envious of the bit. Of course, I like to think I'm a bit more like that, but sadly not. What are the limiting factors? And we're talking about not just modelling here, we're talking about any development. Okay, and I think this is changing with the new generation that's always on their iPhone. That means you, by the way. Yeah, I know best, it takes too long, I can't be bothered, I haven't got time, I've been doing it all my life, it's expensive, I can put a stent in there, I can treat you, I don't trust it. There's a lot of psychology. And I find this deeply fascinating, and I think we're going to have to unhook ourselves from convention and got to move with the times a little bit more quickly in medicine. The other thing I've noticed is this, interactions, okay? It's become incredibly trendy to have one of these, a multidisciplinary team meeting, yeah? And the idea is that everyone sits around and discusses the patient, you know? The doctor, the nurse, the social worker, the physio, whatever it is. I don't think I've ever been to one with quite so many people. I don't know what that would cost, but usually it's 3 of us or 4. But the way these things work, they look at somebody, actually it was Henry, wasn't it? It was you. You said to me, how do you put together an ECG, an echocardiogram, angiogram? You know, the answer is staggeringly we don't. Honestly, we look at the ECG, leaf through the notes, flag up the echo on the screen, and look at the angiogram, and then put them together in our head. You know, it's not co-registered or anything like that. That would take time and money. It's all up here. And as for what this lot decide, well, who knows? And who's missing from this group, by the way? The patient, yes. Well done. Gosh, we ought to get you along. And then there's organisational issues. So I'm supposed to bring I mean, I haven't even... There's uncertainty at every level, isn't there? I mean, all of you are thinking in your own take on this talk what the uncertainties are. I've tried to change the process, and we've met with a little success in South Yorkshire, but really and truly to put this lot together, different professions, different ways of thinking, different levels of understanding, you know, it is a challenge. Okay, where does the model fit in? Who believes it? And is there a model of this? I think we've got some public health people here. Yeah. You know what an early stage we're at. And when I'm at the front end, okay, but I take my hat off to you guys to try and get this lot sorted out, because I couldn't. And then I've touched on regulation, I won't mention that. Just last couple of slides, the future. So many aspects to the future, I came into this from the aspect of being a heart doctor, treating arteries, treating patients with arteries, putting stents in patients with diseased arteries. The next stage for the measurements is probably to model the flow better, and I've mentioned the scale issue as well. And we've done some work on that, and we're now moving into proper blood flow rather than just a pressure. But at the end of the day, I've decided that for me, you can only do so much. You know, we need a bigger team to go down all these channels. So my goal is simply to get virtual computed FFR into everyday management. It's a sort of semi-achievable. If I can do that, I shall die, probably of a heart attack, quite happy. And I'd just like to thank the team. You may recognise 1 or 2 faces in there, but thank you for having me, and I'm open for questions. So,
How much is it to invest in your company?
I haven't yet got a company, but Sue, who's our business development, she keeps saying you ought to spin out. But the problem is I haven't got any time to, you know.
All
So
right, questions, please.
How do you model the walls of the arteries?
rigid, and we model it from two orthogonal. Crikey. I expect a dove to come down. Two orthogonal views. It's very simple.
And it's sufficient?
It's sufficient at the moment, but good point. We want to look at distensibility, which we're not. Most of these arteries are diseased and rigid. And the model, if you just take two views, of course, just gives you a turned chair leg. It gives you a very simple representation, but it seems to be good enough, astonishingly. There is a trade-off of computational time, which I don't have to explain here, against accuracy. So we want something that's clinically usable, pretty accurate, and pretty quick, and that's where uncertainty comes in. How much uncertainty are you prepared to have? We could use a supercomputer and spend a week getting a really accurate model. Is that usable or practical? No. Yeah, there's one there as well.
If you presented the surgeon with your model plus some quantified uncertainty around it, would that help or hinder them in making the decision?
Okay, so the question was telling the surgeon about quantifying the uncertainty. Surgeons have big hairy hands. Do I need to say any more? The concept of quantifying uncertainty for that, a surgeon wants to know, am I or am I not going to operate on Mrs. Jones? They want to know, am I going to put 2 grafts or 3? It's as simple as that. If I can persuade them that in all probability, let's say 95%, rather than the 99.5, which I don't think we can achieve, to be honest, you know, unlike the talks you just heard. But if we could give them the 95% confidence intervals that getting the graft just beyond the second diagonal will sort out, or is most likely to sort out, most of the patient's symptoms, that would be an achievement. Yes?
So really the question actually is about the wall of the arteries again. How smooth are they, and can you treat the blood as being homogeneous in its material properties?
Yeah. So we treat it as a non-Newtonian fluid, and the walls are very much not smooth. If you've got smooth arteries, your angiogram looks perfect, and that's fine. We don't need to model, because even I can look at it and say, that's great. If it's very narrow, we probably still don't need a model, because you're going to need it treated. You're clutching your chest with chest pain, you've got hardly any blood flow. Who needs a model? But there's a large number of patients in the middle. I had one yesterday. Honestly, I'm not making this up. I had a lady come along and she got slightly iffy symptoms. We call them iffy symptoms, you know. Maybe it is, maybe it isn't. I thought the angiogram's going to make it all clear. It didn't. She had a sort of 60% narrowing. Now, you know, I'm sure you all know enough physics to know that you've got a tube with fluid flowing through it. Not a lot happens till you get to sort of 70-80% narrowing. And then, of course, it's difficult to interpolate that narrowing from the angiogram because it's two-dimensional. But anyway, she had 60% in one artery and about 50% in another. This is by eye, by the way. This is my computer. Yeah? And incidentally, you can do quantitative angiography, and it's dismal, because then you get a whole science of edge detection. You know, you've got grey against grey, and you've got to set the parameters. So your uncertainty there is very difficult. And actually, it turns out that the human eye and the occipital cortex are not bad. They're probably as good as the quantitative angiography. But anyway, she had a 60% long lesion, 50% moderate lesion, and 2 small branches that were much more narrow but too small to treat. What the hell am I going to do? Very difficult.
I was interested in the attitudes of your colleagues and their claims that they don't need this technology.
Mm.
I wondered, essentially, are they saying that their decision making, because they've got their own internal model that's a bit like trained on all of the experience that they've had.
Yes,
So in some sense, are they saying that
that's beautiful.
your model adds nothing to their internal model, and could you somehow do experiments to prove either that it
Yeah.
does or it doesn't?
Can I ask you a quick? Did you just think up that concept of them having an internal model?
Well, I've thought about it before, but yeah,
Yeah,
I
because
don't know about it.
yeah, I've been thinking about it, and of course, I realised about a year ago, no longer than that, that that's exactly what doctors do. They build internal models. We've never used that terminology, and we feed in uncertainty to that model, but we don't use that terminology. And we sit in those MDT meetings, and we don't talk about percentage uncertainties. Anyway, what was your question?
Well, like,
Oh, my colleagues, yeah.
if you
Model.
think that everyone's
Yeah.
running their own model in their mind, and you have this extra piece of
Yes.
that adds to your model, are
Yes.
you somehow can you do experiments, almost like a trial where some of them use it, some of them don't?
Yes,
compare them over
we're
some
doing it
time?
at the moment.
Oh, excellent.
Yes, well done. Yes, absolutely. And we're trying to debunk that. There is a certain amount of literature showing that if you just look and you make your own decisions, I hinted at it with the 26% change slide. You saw those two titles there. So yes, you get a 26% improvement in outcomes, and I'm talking about deaths, heart attacks, thrombosis. These are important things if you use the pressure wire. And I'm hoping that the pressure model will be just as good or non-inferior, because if it is, then we can apply it to lots and lots more people, and we won't have to spend money on the pressure wire. But again, you've raised just a beautiful point about their attitude. And I've got them I can see them in my mind's eye now. I know who they are. It's not as if they don't believe. They just think, I've been doing this for ages. I put the stents in, the patients leave hospital, that's it. And the problem is, I think, that they don't follow them up as individuals for the rest of their lives. It's very much a cross-sectional window. So their model is not fed by outcome. So we've talked about inputs today, and we've talked about outputs. And the outputs should feed back, shouldn't they? So they enrich your model. I've learned that. Hasn't enriched their model because they've not collected the data. Yeah, yeah. Vincenzo, we can have the lights up. He's outside having a fag, I think.
Yes, yes.
Yes.
No, the gentleman was just...
Well, I'll come to you. Lady at the back will come to you in a minute. Who's? Yeah, gentleman in the middle.
Help can be given by people that are in this room. Is this a constraint, or is it perhaps collating the data that's a constraint? What could help?
Thank you for that incredible question. How could this group help? How could people help generally? Answering it, what you go on.
The related part of that is, of course, with medical data, one of the key bottlenecks
Yeah,
is the access to it, obviously because of the sensitivity of it, and also collating different data sources, as you alluded to,
Yeah.
on the same patient even.
yeah, yeah. Okay, so thank you for giving me my answer. Because it's a really hard question to answer, but there are various bits to it. First of all, the data. Yeah, that's a big problem. So IT in the NHS is very poorly collected. It's not well centralised. I would love everyone to be on a single database and for us to tap into it and ask sensible questions like you've just asked. Because if everyone knew that if you had a pressure wire test, that group did better in the real world of the UK, Europe, the world, than ones who didn't, then the regulatory bodies will be onto that like a shot. At the moment, so that brings us on to regulation. NICE endorse the pressure wire, and we hope they'll endorse the model of the pressure wire when we get it. But they can't mandate it. So in any health service economy, let's take the UK because we all understand that in this room, your hospital, your doctor will use and spend money to buy the software or the pressure wire because it's endorsed by NICE. But they don't have to, and if they're strapped for cash, they won't. No one's going to come knocking on the door saying, you didn't do a pressure wire. Other aspects of your question, how can we help as a community? Everyone who's in hospital should sign up to medical research. That's the first thing. So, you know, when you go in, we should all be in a clinical trial. That's my strong belief, and we'll never understand otherwise. All my patients, I get them to sign up, say, they don't mind. It's fine. It's all anonymised, this anyway. You all understand that. These data are anonymised. And it really helps. As far as this room is concerned, I'm not sure, because it's the first time I've spoken at this meeting. I'll have to talk to Peter about that offline, I think, and Richard Clayton, who I know. What do you think? Yeah, did you want to answer that?
No, sorry, quick question. Would you...
Okay, just wait one, because we've got that lady, then you. But I just want this gentleman to say how you think... Sorry?
It was just about what you said about the...
Oh, okay, sorry.
Is it okay to sign up and get the placebo, for example?
The ethical...
Yes, yes. The whole idea of medical research is the placebo group is the current... It's not no treatment. It's the current standard.
Okay.
Okay? So all you're signing up to in a clinical trial is the current standard versus the new hypothesis.
Okay,
Yeah.
because sometimes it's, you know, publicly placebo is understood as like, you know, we give you something but it really means nothing. So maybe it would be good to clarify.
No, for instance, if you're trying a new cholesterol drug, you'll have the standard old cholesterol drug in the placebo group, just as a crude example. Can I come back to you?
We're getting ready. So there's somebody, the lady at the back was...
I'll see you over coffee. Yes.
Somebody at the back.
Yeah. I've not forgotten her.
Yes.
I was interested in your picture, and you said you liked the fact that there was a pretty picture that kind of helped you make a decision.
Yes.
But on the basis that research is limited, if I focused on a pretty picture that made the decision for you, so I'm doing decision theory, so that I've come up with this is what you ought to do, is that better or worse than improving my picture to enable you to make the decision? Because that's two different...
It is. Thank you for bringing it up. And that has implications for regulatory approval. If we said, it's red, you must put a stent in, then yeah, that's kind of a treatment. And that's a class 3 MHRA device. It's like an operation. Not suggesting that. I'm suggesting we give the pretty picture and the number. Reason, if you think about it, through the whole history of medicine since Galen, doctors and all health professionals are used to making decisions on the basis of bits of evidence, however uncertain they are. Yeah? So these patients will have had, let's say, a treadmill test. They managed, let's say, 6 minutes, and let's say they got 1 millimetre of ST depression on the ECG monitor at the time. That information goes to the doctor. It doesn't say in big flashing letters, you must treat. It's just the information. It's the data. It enriches the decision making.
So our models could bring that data together
Yes.
to give you a single sort of number, or we could take all of those things and let you bring... Where on that scale are you comfortable with us making the decision and you making the decision?
Oh, right, okay. Help. I don't know. I think we're used to very clear tests sometimes, but we are also used to a lot of tests that give you a result, and it's the interpretation of it. Never forget that the data that feeds into a model is only as good as, well, you're an expert obviously, you're nodding away. So, say it's your mum. How could we have enough holes in the spreadsheet to populate with all the parameters that make your mum? I don't think you could.
We've actually we've managed to work our way wonderfully through the second session of the virtual work. I think this provides me with a wonderful
Opportunity to get me off
Thank you
the
very
stage.
much.
Yeah.